All right. How are you feeling today?
Hey guys, I'm Rishi Desai, the Chief Medical Officer here at Osmosis, and I want to talk a little bit about infective endocarditis today. So, we're going to talk about a few different topics. The first one being signs and symptoms of endocarditis, specifically infective endocarditis. So, there's an acronym, a handy acronym to kind of go through this, and it is from Jane. So, just think maybe you got endocarditis from Jane, although it's not contagious. So, from Jane, F stands for fevers. From R stands for Roth spots. Just think of the eye exam. O stands for Osler nodes. So I think of ow, Osler. Ow being because they're painful or tender. M is murmur, so heart murmur. Jane, so Jane, Jane is Janeway lesions. And I think, oh, just Janeway, meaning, oh, just, they're not painful, they're just Janeway lesions. So they're distinct from the Osler nodes, which are ow, Osler. A for anemia, N for nail bed hemorrhages. So I'm showing my nails, but nail bed or splinter hemorrhages they're sometimes called. And E for emboli. So sometimes you'll see embolic phenomenon on a CT scan or an MRI or something like that. And that's often evidence, again, of something that's kind of spewing off of your valve and kind of seeding other parts of your body. So from Jane are the signs and symptoms. Next, let's move down to diagnosis. And for diagnosis, you really want to, there's Duke's criteria, and many of the things that I just went over are part of Duke's criteria, specifically minor criteria. But for the major criteria, the big things you want to think about are two: blood cultures and echo. So the blood cultures, basically you get large volume blood cultures, you see if anything grows out. Typically, it's going to be, something like staph aureus or staph epi or enterococci or streptococci. So those are your most common organisms. There are some very uncommon organisms that are very uncommon, but you should kind of keep a lookout for. Coxiella being one of them that often kind of people will mention because it's tested using titers. But anyway, those are the blood cultures, so you just see what the lab grows out. The other one being the echo, and the echo is actually kind of the interesting one from my perspective, because I always thought it would be a vegetation on the valve that you're looking at, and that would be like, oh, endocarditis. Oftentimes it's something that's much more subtle, so it's like a change in the way that the valve moves. Maybe there's a new regurgitation, or sometimes it's literally just the way it's moving is a little bit more stiff, or it's not kind of moving as flexibly as it was on a prior echo. And sometimes people have prior echoes if they've had cardiac surgery or something. So you can kind of compare and contrast and say, hey, is this valve looking the same as the previous one? So those are the kind of two keys that you want to look at. And then if there's a prosthetic valve, dehiscence of the prosthesis is a classic example of what endocarditis will do. So if there's any evidence of dehiscence, then you want to make sure that you investigate for endocarditis. So those are the keys around diagnosis. And then treatment, classically, it's going to be bacterial, right? So it's going to be empiric treatment with antibiotics, and specifically something like Unison and Gent, or, if you're thinking about vancomycin, it might be Vanc, Gent, and Cipro, or sometimes rifampin is added on, especially around prosthetic valves. So it's going to be some combination of those antibiotics. And usually that's just for a few days until you actually get a culture back. And once you see the culture and the susceptibilities, you can say, okay, let's just change the antibiotic regimen accordingly. That's all well and good. The key, though, is the length of treatment. And I say the key because sometimes you have to treat for a long time. And with prosthetic valves in particular, sometimes you'll treat for a long time and it still won't work. And you'll have to get a surgical replacement done. And so just keep in mind that with prosthesis, I often think of prosthesis as being kind of like plastic in a way. And antibiotics don't treat plastic very well. As you can imagine, plastic doesn't have blood vessels, so antibiotics can't get to plastic. So if there's an infection of any prosthetic material, it's very hard to treat with antibiotics alone. So usually end up having to take out that valve and surgically replacing it. So anytime there's prosthesis, antibiotics are usually going to be tried at first, and oftentimes it fails, and then you have to just surgically replace. So that's the keys on treatment. And then one clinical pearl I want to kind of leave you with is just thinking about endocarditis as being a biofilm infection. So you think about biofilms as being bacteria, and then they're stuck in this mucus, right? So essentially what happens is antibiotics have a hard time getting through that mucus to get down to this bacteria that may be at the bottom. So the key there is just length of treatment. You end up giving antibiotics for weeks and weeks, as opposed to, let's say, a UTI or something where you give it for maybe 3 days or 5 days. With a biofilm infection, usually giving antibiotics for a long period of time, because the way that we essentially try to counter the fact that diffusion is what we're kind of waiting on is we just let it last for a long time, and over time, the concentration of antibiotic around the bacteria gets high enough to where the bacteria will die. So that's why the length of treatment for endocarditis is so long. I always kind of wondered about that. It's essentially because the biofilm infection is what we're dealing with. So anyway, I will leave you with that, and I hope that helped you understand some clinical aspects of infective endocarditis. Thanks a lot. Bye-bye.
Start your free trial today at osmosis.org.